Hello, everyone. Thank you for joining our webinar tonight. My name is Lauren Steffes, and I'm the marketing specialist here at OSMS. Tonight, we have Dr. Paige Chapman with us to talk about hand and wrist arthritis. She is a hand, wrist, and elbow specialist. Just so you are aware, we are recording this webinar, and the recording will be made available on our website at osmsgb.com/webinars by the end of the week. If you have any questions, please leave it in the Q&A box, and at the end of Dr. Chapman's presentation, I will be asking your questions to her for her to answer. But before we even get into her presentation, I just have a few facts that I want to share about OSMS that I'd like to go over. So if you are not already aware, OSMS is a doctor-owned orthopedic sports medicine, rheumatology, and pain management practice. We have 9 locations across Northeast Wisconsin. So our farthest north is Marinette, farthest south is Fond du Lac. We have 25 orthopedic doctors, so that includes our orthopedic surgeons and our non-operative physicians. We have 8 rheumatologists, and then we also have 3 pain management doctors. In our main locations, we have a full range of services on site, including X-ray, MRI, CT scan. The DEXA scan is a bone density scan, and then EMGs, that is a nerve conduction study. All of those will be helpful in diagnosing your pain or injury. And then also for rheumatology patients, we have infusion suites that are semi-private. That is where they can get their infusions done or their medication via IV. We have surgery centers in both our Neenah and Green Bay location, and then a walk-in injury clinic in our Neenah, Green Bay, and now our Oshkosh clinic. So for those of you who don't know, we did just open our new clinic in Oshkosh at the beginning of April. And then also on site, we do have physical and occupational therapy partners. If you ever find yourself in pain, but you're not sure whether you should come in and be seen by us, we do have a 24/7 free chat service for you to use. So you can get connected with an orthopedic expert anytime, anywhere, and they will give you guidance on your pain or injury. So they may give you some at-home exercises to try, or they may say, "Ooh, yeah, try to get in with OSMS, make an appointment. That sounds like something that you should be seen for." For those of you who don't know too, we did extend our hours in our Green Bay and Fox Valley clinics. So Monday through Thursday, we're open 8 a.m. to 7 p.m. And then Friday, we're open 8 a.m. to 5 p.m. We just wanted to make sure that you guys could be seen anytime that you needed to be. Or give you more time to be seen, because sometimes it doesn't work between 8 a.m. and 5 p.m. All right. Yeah, I'll hand it on over to you, Dr. Chapman.
Thank you. Hi, I'm Paige Chapman. I'm a Midwest native, originally from Michigan, and I started here in March as one of the orthopedic hand surgeons. Today, I'll be talking about hand and wrist arthritis. This is just a little schedule of what I plan on talking about. Kind of going over a little bit of like, what is arthritis? How do we diagnose arthritis? What are some of the treatments for arthritis? Because I'm talking about hand and wrist specific, I did want to talk a little bit about the hand anatomy, and also specific treatments to those specific areas of arthritis. Another thing I will touch upon at the end is complementary or alternative medications and what to do if you think you have arthritis. So first of all, what is arthritis? So arthritis is basically an inflammation of the joints. What happens is you get inflammation, and this causes destruction of the cartilage, which leads to pain, crepitus, stiffness within those joints. This can happen to any joint, whether it be the small joint of your finger where your fingers bend, or your wrist, elbow, shoulder. You can get it in your spine, hips, knees, anywhere there's a joint, you can get arthritis. There's different types of arthritis. One of them is osteoarthritis. And the reason I have a picture of a tire here is because that's how I really use the analogy of a tire tread, right? Like as a tire is going down the road and you put more and more miles on it, it gets wear and tear and it wears out. That is what osteoarthritis is like. As you age, as you put more wear tear on your joints, the cartilage wears out. So it thins out just like a tire that is balding. Sometimes this is related to genetics in that some people may develop arthritis earlier or to a greater extent than others. Another type of arthritis is called inflammatory arthritis. What inflammatory arthritis is an autoimmune response. And so what your body does is actually presents antibodies that will attack the cartilage and synovial membranes around the joint. This also has a genetic component, but the treatment strategies for this are much different because of the fact that it is an autoimmune disease. And some of you may have heard of things like rheumatoid arthritis or psoriatic arthritis. Those fall more into this like inflammatory autoimmune type arthritis. And then one thing I did want to talk about is something called post-traumatic arthritis. This is something that happens after you've had an injury causing destruction of the cartilage. This is an environmental type injury. So say you have a fracture of, we'll say distal radius because that's within the wrist. And then 10 years later, you get arthritis. It's because that cartilage was disrupted and the cartilage has thinned out due to that previous injury. We treat this arthritis a lot like we would treat our osteoarthritis. This is just a diagram of kind of the different types of arthritis. So normally you have this nice cartilaginous rim of cartilage on both sides of the joint. The joint is kind of surrounded by a joint capsule and synovial membrane. That synovial membrane creates fluid that kind of keeps your joints well lubricated. Well, in osteoarthritis, as I said, the cartilage kind of wears out like a balding tire, and eventually that cartilage gets so thin that there's no more glistening cartilage, and the bone ends start to rub together, and that is what the term bone on bone means. Is really those two bone ends are now rubbing, and it's causing a lot of friction, pain, and inflammation. The rheumatoid arthritis, as I said, autoimmune inflammatory arthritis is a bit different. And sometimes we see this on imaging studies because we'll notice like bony erosion or a very specific pattern of arthritis that correlates more with rheumatoid arthritis. Both are very painful and can cause significant stiffness and swelling either way. So diagnosing arthritis. So a lot of the ways we diagnose arthritis is with an x-ray. So if you came into my clinic and said, my thumb hurts, it's been bothering me, I will get an x-ray of it. And that will tell me the extent of the arthritis or the specific joint where it is located. It can also sometimes hint to whether it is osteoarthritic, inflammatory, or post-traumatic. And that sometimes you can tell somebody had a fracture in the past that led to disruption of that joint. Sometimes, like I said, we'll see bony erosions or cystic changes that may be more common with inflammatory arthritis. So an x-ray can tell us a lot of things without directly telling us those things. And in addition to that, a lot of things can be found with just a physical exam. A lot of times when I'm examining a joint with arthritis, I notice that there's nodules, as you can see on this picture here. And I'll also just feel the motion of the joint, know that it's stiff, and feel some what I call crepitus, or that crunching sound from that bone rubbing on that bone. If at the time of your visit, we are concerned that there's autoimmune arthritis, then we would order the blood work to verify that. So treatment. So I would say treatments for arthritis are very individualized. It's really based on patient preference and how severe their symptoms are. There's both non-operative and operative treatments. In any case, operative treatment is usually saved for severe symptoms or failure of non-operative treatments. The only caveat to that is if you're diagnosed with an autoimmune inflammatory type arthritis like rheumatoid arthritis or psoriatic arthritis, usually we refer to rheumatology because we want you to start on medications. And the reason we want to start medications is because we found that medication use is what prevents it from getting worse. There's a very characteristic patterns of inflammatory arthritis, and we know that with the medications that rheumatology gives, that it can often delay the pattern of arthritis and delay some of those more severe findings that happen later on in the disease course. So non-operative treatments. There's a lot of different non-operative treatments, and this really just comes down to what works for you. Not all of these are going to work for every single patient. And some people will try one thing, it doesn't work for them. Another patient will try and say they love it. So it's really just trying different things to find a way to manage your arthritis and manage your pain. Whether that be in the course of bracing. Braces usually come in all different shapes and all different sizes, and there are specific braces for specific conditions. These are also very patient-specific, and the response is variable. There's multiple different kinds of anti-inflammatories. I usually suggest people start off with their standard Aleve, Advil, ibuprofen. If those are not working, we do have prescription grade anti-inflammatories such as meloxicam or Mobic is what that's called, or Celebrex or Celecoxib is the other name for that. Complementary and alternative medicines, I will discuss at the end. I have a whole slide on that, so we can talk about that a little bit. Heat and ice. So I usually suggest heat because I think more patients say that that feels better. But if you have acute flare-up or injury and you have a lot of swelling, sometimes the ice may feel better. That is also another patient-specific. I don't think there's a right or wrong answer. I think it's whatever feels best for you. There's all kinds of creams, all kinds of different creams out there on the market, whether it be CBD cream or Voltaren gel, icy hot biofreeze. Again, another one of those, whatever works for you. Some people can't do the Voltaren gel because it bothers their stomachs, but maybe the biofreeze or icy hot won't bother their stomachs, but will still work. We can get people into occupational therapy. Sometimes they can help strengthen the muscles around the joints to just stabilize them a little more. And sometimes they have suggestions on how to interact in the world to combat this pain and stiffness, or ways to do things that are a little bit different that don't put so much stress on your joints. And then steroid injections. Patients tend to do pretty well with steroid injections, but again, the response is variable. Some people find their bodies are very responsive to steroid injections, and some people don't. But I do know when they do help people, some people get really good response, and usually we'll do those every 3 months as needed. And that is something you can schedule an appointment with us here at OSMS and have done same day. Ergonomics. So I wanted to talk a little bit about ergonomics because I think it's something you can do at home to try to help with your pain. Ergonomics is really just this idea that you're adjusting your surroundings to fit your body. And one of those ways is, sitting with a neutral wrist, making sure you're adjusting your work chair and seat, taking breaks. You see here, I have this picture of this, what we call a vertical mouse. Some people find that really a lot better because they aren't quite doing this motion with their wrists. It's more of like a gentle kind of back and forth like this, and they could keep their wrist a little more neutral. They also make all kinds of different aids for, eating utensils and all that kind of stuff. And that would be something occupational therapists can often help kind of guide you with. Okay, so here's a hand and wrist anatomy. So essentially, all of your fingers are made up of 3 bones, the distal phalanx, middle phalanx, and proximal phalanx. The thumb only has 2 bones, which is the distal phalanx and proximal phalanx. And then inside the hand itself, so right along here, is your metacarpals. And then down here, kind of more by the wrist, you have your carpal bones. And there's 8 carpal bones. You can kind of see them all listed out there. And then going one step closer to your body is the radius and the ulna. Those are both the bones that make up your forearm and that rotate around one another for this twisting motion. So I'm going to get a little bit more specific about different areas of the hand and wrist. As far as the fingers go, finger joints are really mobile and they sustain a lot of stress. And therefore, they're really not a great candidate for splinting because they just get stiff. And when they get stiff, they get more painful. And when you get stiff and you have arthritis and you have pain, sometimes it's really hard to get that mobility back. So I don't typically recommend splinting individual digits, as I think it leads to worse outcomes. As you can see in this top picture here, there are different types of joint replacements, but a lot of times these are also not amenable to a lot of stress. So if you were the type of patient who was a laborer or did a lot of things with your hands, these might not be the best treatment option for you as far as surgery goes. Typically, what I recommend is a fusion. It's kind of the tried and true method. And you can see on this bottom picture here, this is a fusion of the DIP joint. So basically that joint doesn't move anymore, but most people end up with like a finger that kind of looks like this. It's straight, but it doesn't really significantly impact them that much. They tend to adjust well to finger fusions. And it just kind of holds that joint steady so you no longer get that bone on bone rubbing. Base of thumb pain. This is probably one of the most common types of arthritis that we see in the hand. It's typically more common in men, or not men, I'm sorry, women. Usually what we suggest is a reconstruction of this joint, and patients do really, really well with that. And you can see the joint circled there. You can see all that arthritis in there. And really, there's just typically a black line between the two bones. And here, because of that arthritis, the bone is touching the other bone. And you can see it kind of looks white, or what we call sclerotic, and that's just from the inflammation in the bone. There are some newer treatment strategies which involve denervation, and a denervation is basically where we go down to the joint itself and we kind of ablate all of the little tiny pain fibers going down to the joint capsule. It's really kind of a hit or miss. It's another one of those surgeries that, works for some people, but doesn't always work for others. But it's a really low, very low requirements for postoperative care. It's really, you can use it afterwards. With a reconstruction of a joint, oftentimes that you're laid up for a good 3 months just because you got to let it heal. But when you do the denervation techniques, a lot of times you could just go right back to activity without a significant delay. These are kind of specialized braces that are for base of thumb pain. They call them a CMC restriction brace or comfort cool brace. These are side and size specific. So you can order these on like Amazon or Walmart.com. But like I said, they are size and size specific. So if it is something you are interested in because you think you have thumb arthritis, we do offer these at OSMS. You can come in and we can size them for you if that is something you aren't sure about. This is just taking one step closer to the body. This is something called carpal or mid-carpal arthritis. This type of arthritis is a little more common with certain injuries, and those injuries would be, if you had a broken bone. Sometimes, like when the scaphoid is broken, what will happen is people in their 20s, or teens, they have an old football injury and they hurt their wrist, and then it gets better and they kind of just let it go and forget about it because it doesn't feel bad. And then 20, 30 years down the line, they start noticing, I'm having some wrist pain. And they come and see me and they have this old fracture that's been in there. And because of that fracture, it changes the mechanics of the joint. So what happens is the bones start rubbing a little differently and you start to get arthritis. And you can kind of see this diagram here where that redness is kind of that arthritis. And over time, that arthritis can spread and become more involved the longer this disease process has been ongoing. So when it comes to this type of arthritis, the carpal and mid-carpal arthritis, when we're looking at surgical treatments, we're usually talking about things like partial fusions or removal of some of the bones. Because what we're really trying to do is just fuse the little joints where there's arthritis or just remove the bones that are arthritic. People tend to do pretty well with this, but at a very end stage disease or a disease that progresses over time, you can end up with a wrist fusion where we basically make your wrist straight and steady, but you still have motion in your fingers. And this is just an example of a partial fusion. You can see a couple of the bones have been removed, but there still is a nice plate there that holds everything together. You still have motion, but it's usually a little more restricted than it was before because it is a partial fusion. And then when we're coming down to the wrist, we're really talking about the radial carpal joint. So that's the joint you see between the radius here, the scaphoid, and the lunate. And then also the distal radial ulnar joint, which is the joint between the ulna and the radius. between your two forearm bones at the wrist. Surgical and treatment of the radial carpal joint usually involves the same thing, where we're talking about partial fusions or complete fusions. And you can see in this top picture is what a complete fusion looks like. That is something we would put that plate on there. That whole wrist would fuse together so it doesn't move anymore. And one of the reasons we do that is because then those bones can't rub. Those bones can't rub anymore if we fuse it. Wrist denervation is another thing. Like I said, for the thumb, we've started doing these denervation procedures where we go down to the joint and we remove the tiny pain fibers going to the joint. Like I said, response to that is variable. It can work for some people, but it doesn't work for everybody. And it's hard to predict prior to surgery who's going to get the most benefit for that. There are total wrist arthroplasties that are performed in the country. However, these are not like a total shoulder or total hip or total knee. These tend to be much more unstable, and the indications are much more narrow. The use in this extremity has to be a lot more limited after this surgery to prevent things like the implant loosening or dislocation of the wrist. And then here is just that distal radius ulnar joint. So this is a really complex joint, because as you can see here where this ulna is replaced with that metal is that bright white structure there. That is where the bones rotate on one another. And so that is what is responsible for this twisting motion at your wrist. There are a lot of different treatment options for this, which can include stuff like replacing that. We can do like a fusion of that, but it doesn't always look like that. Usually we have to give you a little bit of twist, so we don't like to fuse that one alone. All right, so I did tell you guys I wanted to talk a little bit about complementary and alternative medicines. I would say as far as complementary and alternative medicines go, there's not a whole lot of evidence in that. There's a lot of anecdotal accounts that some of these home remedies work. And for me, I think the risk is low, so that's why I mention it. In occupational therapy and different therapy groups, they do use like paraffin wax baths. It's basically just like a heat. People think it feels good on their hands, maybe after a long, hard day where your hands are going to be achy, trying that kind of thing. You can get them on Amazon for $30 or $40. The risk of that is just if you turn it too hot and you could burn your hand, really. There's a whole bunch, I just listed a couple here. There's a whole bunch of home remedies you can look up on, like a turmeric supplementation, tart cherry juice. There's this grape juice plus pectin. Gin-soaked golden raisins is one I've heard of. You're supposed to eat a couple of golden raisins every day. This website here, thepeoplespharmacy.com, is one that has a lot of these home remedies listed out. Another one that I didn't list on here is like glucosamine-glycan supplementation. A lot of those supplementations, they're low risk, but it's hard to know the yield you will get from them. So I mention these things as something you can try, but we don't have evidence that they work. It's just something to try to help manage pain that some people have anecdotally said helps them. So what should you do if you suspect you have arthritis? You should really probably get it looked at. You can make an appointment with one of the OSMS orthopedic surgeons. We're all orthopedic surgeons here. So even if you have hand or wrist, like let's say you get a total knee done by one of the doctors here, and now your hand or wrist is hurting you can see your total knee doctor. They can get x-rays, they can look at it, they can tell you what they think going on, because we're all orthopedically trained here. And that means we've all had some experience in the hand and wrist. There's a couple of us like myself who are more inclined to hand and wrist and did a specific fellowship in that. But if it came down to it where you needed like a surgery or something like that, usually your surgeon can transfer your care to one of us if needed. But a lot of those guys do feel comfortable doing hand and wrist surgeries and working those injuries up. At the appointment, you should expect to receive x-rays of your affected joint, and your doctor should look at the joint and perform a physical exam. As I said before, a lot of times I'll feel like some crepitus, or when I move that joint around, I notice it's painful and things like that, which lead me to believe it's more arthritis. Depending on the type the severity of your arthritis, and the location of your arthritis, different treatment options will be presented and tailored to you for what your preference is, because not everybody comes to the orthopedic surgeon and wants surgery. And I realize that. And so do my colleagues here. And we really want to tailor your care to you and like what you have going on in your life. Because I get people who look at me and they say, Dr. Chapman, I am so busy. I work a laborious job. I can't take 3 months to rehab a reconstruction of my thumb. And that is okay. Here at OSMS, we do have same-day appointments available. Like I said, we do have braces and we do have injections that you can get same day if you so need one or choose to go that route. So in summary, arthritis affects many people. It can involve any of the small joints of your hand, any of your little knuckles. It can affect any joint of your whole body, actually. There are many treatment options. Usually we try to tailor these to patient preference, and it kind of depends on location of the arthritis, on the type of treatments available for that specific joint. Orthopedic surgeons can offer so much more than just surgical surgery alone. And here at OSMS, we do have a rheumatology clinic. So if it is determined that your arthritis has come from an inflammatory source or an autoimmune source, that is something we can kind of help you get into, because rheumatology can sometimes be really hard to get into. And that's kind of a nationwide thing. They're always really backed up. All right, I think that is it.
Wonderful. Dr. Chapman, if you want to stop sharing your screen, we'll get on into our Q&A session. So just to remind you guys, please put it in the Q&A section. I will go through and try to address as many questions as possible within the allotted time that we still have left. However, if your question isn't answered live and you, of course, still want to get your answer, we encourage you to give our office a call or to schedule an appointment. All right, so I see that we already have some questions in the chat, so we will get started on that. Dr. Chapman, do you want to explain some of the conditions and injuries that you see? Because someone is wondering if you do finger joint replacements.
So I will do MP joint replacements. I don't typically do the small joints like the PIP joints, but the MP joints. That's just because those, when you stress those joints, they tend to not last a super long time because they're just more prone to stress. So it's not something I typically recommend. And then especially for like what we call border digits, which are your small finger and index finger, those just take a lot more stress, and your thumb take a lot more stress because of, they don't have the support like the middle and ring do.
Wonderful. So then with those, of course, if someone wanted to see you and it ends up being one of those that you don't do a joint replacement with, of course, you would talk them through the other treatment options that you would.
Yes. Yeah. We could talk about other treatment options. And I have sent people to get like ultrasound guided injections. We have non-operative, pain management physicians, who do a lot of ultrasound guided injections. So they really can target that small joint. Yeah.
Yeah, absolutely. Okay, great. Are there any dietary suggestions to rebuild cartilage?
There really aren't, because once cartilage is lost, especially in adulthood, there's really no way to get it back. I'm sure there's a lot of scientific studies out there right now trying to investigate this and find something to help with that. But once it's kind of lost, it's just lost, unfortunately. We find in like children who are growing, they have a lot of the growth factors to regenerate cartilage. So if they get like a cartilage injury, sometimes we'll find that the cartilage grows back on its own, but it never happens in adults, and there isn't anything currently on the market for that, unfortunately.
Great, thanks for clarifying. So you did mention during the first appointment you would take an X-ray. Someone is wondering if an MRI will show arthritis or if it will just show inflammation.
It can show both. We can see the cartilage thinning out and narrowing on an MRI, but the best imaging study is an X-ray. MRIs are better for ligament and tendon injuries, but we can see things happening in the joint like narrowing of the cartilage as well.
Okay. So unless you feel like an MRI is absolutely necessary for the diagnosis, you would only do the X-ray.
Yeah, so if I get an x-ray and it's very clear severe arthritis, and we don't typically get an MRI because we have our answer already. If it's something where your symptoms aren't quite correlating with the x-ray, so let's say we get an x-ray and it's mild findings or it doesn't quite explain your symptoms, then sometimes we get an MRI.
Hmm. Okay. If arthritis came from repetitive factory work, what kind of arthritis would you typically say that it could end up being?
So out of the three that I mentioned, it's usually osteoarthritis because of the fact that it was kind of wear and tear over time, just from that repetitive motion.
Is your choice for splint for CMC arthritis the Comfort Cool brace, or are there any others that you would recommend?
Yeah, some people use what we call a thumb spica, but that's got some like metal in it. It's a little much bulkier and restrictive. So I typically recommend the CMC Comfort Cool or what's called a CMC restriction brace because it's kind of like a neoprene sleeve with just this little wrap around your thumb. So it's a lot less bulk and people just it just supports right where you need it, right over that CMC. Whereas the thumb spike, it comes all the way out to the tip of the thumb. And you really don't need, like this little tiny joint immobilized. It's really this here that needs to be immobilized.
Great. What are some exercises that are used for wrist pain, whether it is, I know I have arthritis, but I want to put off surgery or even post-surgical?
So, I mean, it's really just trying to like strengthen that wrist. I think I mentioned earlier about the ergonomics of keeping a neutral wrist. You want to keep a supple joint so that way the joint can have good motion. So any kind of like wrist stretch, like this kind of thing can usually help with mobility. And then just to support the joint, we say we want to work on some light strengthening. I don't think we need to go into like bodybuilding type lifting, but just, light weights around the house type of thing. And um, we can always send somebody to occupational therapy too, who can kind of help tailor a program or a plan to your specific needs.
So if someone were to try doing like these stretches, how long would you recommend for them to hold it? Is there a certain specific amount of times during the day, during the week that they should do those?
I would say at least like 3 times a day. Working on holding for 10 seconds, 10 times each session type of thing. Just like I said, to just keep the motion supple, prevent it from getting super stiff.
Great. And then another question going off of that, just to make sure that we get this answered in the full capacity. So we do have our PT exercises that we do have on our website. Are there any that you recommend for the wrist? Or I mean, I know that you would also probably provide them to the patients, during their post-op or whatever it may be.
Yeah. I mean, we have a general exercises for the hand and wrist on our website, which are actually pretty good and comprehensive. So I would just start with that. And like I said, if you don't feel like that's meeting your needs or it's not really doing much for you, you're not really sure how to do those movements, we can always get you in with a specialist.
Um, So someone is wondering if they'll make an appointment, will they see you or the PA? You will always be seeing Dr. Chapman. So that is one thing that we take pride in, is that even at whether you are coming into our walk-in clinic, if you don't know who you specifically need to see, you just know that you have pain, and you go into our walk-in clinic, either way, you will be seeing one of our physicians instead of an NP or a PA.
Yes.
Are there any dietary suggestions? Oh, that was the same question. Someone thinks that they have a ganglion cyst in their wrist. Is that something that would be removed?
Yes, ganglion cysts can be removed. It depends on the location on where it originates from or the side of your wrist it is on. Sometimes we get an MRI if we're not 100% sure because we like to get to the stalk of it. And sometimes having arthritis can lead to a ganglion cyst because that joint breaks down, so that joint capsule kind of forms an outpouching and it fills with fluid, which makes the cyst. And so as time goes on, that cyst can get bigger. Sometimes it can get smaller as your body resorbs it and kind of gets some of that fluid gone, but then it can get inflamed again and get larger. So it is something we can remove if it's bothersome.
Right. What clinics do you see patients at, Dr. Chapman?
I am at Green Bay and Marinette on Wednesdays.
This person says that they have arthritis in their thumbs and their thumbs are weak. Can you recommend any strengthening exercises specifically for that?
Strengthening for the thumb. So I would recommend, a lot of like this type of motion. So trying to bring your thumb to your small finger and just holding it just to try to build up some of this muscle around there. Alternatively, trying to like do it against like a weight or like a grip to try to increase that grip strength a little bit. Sometimes it's hard with arthritis because occasionally it can be pain that is limiting and causing the weakness, not just weakness because the muscles are weak, if that makes sense. So sometimes trying to get your pain under control or trying to find things that help with the pain can then help alleviate some of that subjective feeling of weakness.
Okay, sure, that makes sense. Are there any foods that someone should avoid to prevent inflammation?
I wouldn't say there's any like specific category of foods. I would say that in patients who have a predisposition for like diabetes and metabolic syndrome, watching their blood sugars and keeping that well controlled can help reduce a lot of the inflammation in their bodies.
Do you know whether denervation procedures are covered by insurance, especially Medicare?
It would be insurance specific. From what I have witnessed, I have not had a insurance to decline it, but whenever we do a surgery, like if I book you for surgery, we always have a set of staff who talk to the insurance companies and make sure everything is approved before we go further on or actually do the surgery.
Yeah, for any questions that anyone has about insurance and coverage, we highly recommend reaching out to our business office, and that can be found on our website. They'll be able to answer any questions about coverage, about whether we cover your insurance, and we cover most major insurance plans. So, but they'll be able to answer it more specifically and specific to your insurance. Can you explain? I'm going to butcher this word, so I apologize. But can you explain seronegative arthritis?
Seronegative arthritis. So that's a term they use in rheumatology. And what seronegative means is it means that they did all of the blood work and none of it was positive. So it's all negative. So what seronegative typically means is that the rheumatologist feels that your symptoms and your type of arthritis correlate with like a rheumatoid or autoimmune or inflammatory type arthritis picture, but your labs are normal. So it's basically like them saying you have some form of autoimmune arthritis, but the labs are normal, which can happen in a certain percentage of people.
This particular person has had 2 knee replacements and one total knee done at OSMS. They're asking, should they start by seeing that surgeon regarding their hand and wrist pain, or do you recommend seeing someone else?
You can do whatever you're comfortable with. If you really have a good relationship with your surgeon, it is more than fair to go see them and they can get the initial workup going. They can get your x-rays done. They can take and examine that body part. And like I said, if the general orthopedic surgeon feels, this is not something I typically take care of, then they'll transition your care to someone like myself or Dr. Zellner, who's the other hand and wrist specialist. But starting with your surgeon that you know and you feel comfortable with is completely acceptable.
Absolutely. And no matter what is decided, of course, the doctor that you go with, if they're going to transfer your care, we're going to make it as smooth of a process as possible.
Mm. And I would say most of the orthopedic surgeons here would feel comfortable doing, like I said, small joint injections or giving you a brace or helping with some treatment strategies, you know, um, to help you feel more comfortable sooner. So you don't have to just necessarily wait.
And of course, it all depends too when you want to be seen. If you want to be seen sooner rather than later, and someone else has an opening before that specific doctor that you were seen in the past with, it's totally up to you if you would want to be seen sooner with someone else or wait. So, but like Dr. Chapman mentioned before, we do have same day appointments available if that's something that you're interested in. What do you do with a disfigured fingertip? Pointing or bending in the wrong direction versus having a straight finger?
So a lot of times, once the arthritis has set in to a point where the fingertip is starting to bend one way or the other, usually that means that the cartilage has just been completely disintegrated. So at that point in time, there's not a whole lot of non-operative treatments. Like I said, splinting doesn't really work in the fingers all that well because they just get stiff. And what happens is the joint kind of wears out unevenly. So as one side wears out, the finger starts to turn that way. As the other side wears out, it starts to turn the other way. So the surgical solution for that is what we call a fusion, or where we put a screw down that joint, and we can even the joint out by kind of wearing the bone out, depending on the side that's kind of more or less worn out to just even it out. So unfortunately, like I said, there's not great non-surgical solutions for a finger that's kind of starting to bend out of place.
That's good to know. Um, do you know anything about if collagen helps?
Yeah, that's another one of those kind of complementary and alternative medications that really we don't have great evidence for. There's just nothing out there that really suggests that it rebuilds or stabilizes cartilage.
Sure.
It's probably low risk, I would say. So if you wanted to try it, I wouldn't have anything against that. But I don't know that it's going to, make your cartilage better or, decrease your arthritis pain.
Mhm. Okay, sure. If having a CMC injection, how long can you expect it to provide relief?
So that's a really variable. A lot of I've had patients have relief up to like 9 months or a year. And then I've had some who said it really didn't last more than a couple of weeks. So it's kind of variable. It really depends on the patient. We usually do them as soon as every 3 months. So if you get one, it's hard to say. Some patients also just seem to not have a great response to steroid injections. They'll tell me, oh, I had an injection in my shoulder before, it didn't do anything. I had it in my knee, it didn't do anything. So those type of patients, I usually kind of think it's probably not going to last as long. But like I said, it's really variable and sometimes it's hard to predict. Like I'll have patients who on x-ray have severe arthritis and I would be like, there's no way the steroid injection is going to work. And then they come back a year, 2 years later and they're like, oh, that worked great for 2 years. So
Mm-hmm.
it's always really hard to say how an individual response is going to be. But I would say I've had people where it lasts, a year, but then I've had
Mm-hmm.
some who maybe only a couple weeks.
Sure. And do you find that most patients they'll get multiple injections, or is it kind of just more of like we'll get the injection one time and then kind of go from there?
Um, so I get people who get multiple injections because they're just not ready for surgery. They're like, I don't want surgery. The injection worked. And so sometimes they come in like clockwork. Every 3 months, they get the injection. Feels good for a while, then it starts to wear off. Then they come in 3 months later. That's not a bad treatment option if you are interested in injections, and you're not at a point in your life where you feel like you're ready to have surgery. And then there are people who get one and it lasts a long time and they don't really feel like they need another one. So it's kind of variable. And then I have some who get one and it lasted a little bit, but they're at a point in their life where they are interested in surgery and want to just get it done and over with kind of thing. So it's really another one of those patient specific things. I think it's kind of one of those things that it doesn't really hurt to try, especially if you've had good relief with other injections in the past.
Sure. Are you in favor of rubber band intrinsic hand strength exercise?
Yeah, yeah. I mean, I think anything you can do to kind of keep the hands, mobile, and prevent stiffness, I would be down. I would be okay with that kind of thing. Yeah.
If so, this person is asking if they have a thumb joint replacement, could they do rehab in Florida over the winter?
Yeah, if you had a location in mind, the only thing is I would want to see you periodically. So, usually we have a follow-up at 2 weeks, 4 weeks, 6 weeks, and then, 2 to 3 months out to make sure everything's looking okay, make sure you're doing okay. You could after that then, yeah, go to Florida and, see OT down there and have them work with like strengthening and mobility and things like that.
Can the small hard lumps on the side of the finger and thumb joints be removed? Are those bone spurs?
Yes, those typically tend to be bone spurs, and they're not typically something we can just remove because what happens is once you start removing those, the joint becomes unstable. So it's another one of those things where if it's painful and bothersome, we would likely fuse that joint and shave it down to smooth it out so it's straight. But getting rid of those bone spurs altogether usually can lead to some joint instability. So it's not something we recommend, and it doesn't always improve pain. So that's why
Okay,
we don't do it. Mhm.
sure. I'm sure pain level for patients vary, but how would you say the injections are at the base of the thumb?
So I don't think the needle itself is what's painful for the injection. I think it's the pressure from the fluid because that tends to be a really small joint. Um, I would say the pressure people don't love. I've heard that injections in your feet are a lot worse. So if you ever had that, you can compare it to that. And I've had some people say the knees are worse too. But unfortunately, I haven't had the pleasure of having an injection in either. So I don't have any personal experience to share. But I will say people don't, it's probably not the worst injection that we can do, but it's also not the most pleasant.
Hmm. And if people are to get injections and they do find that there is discomfort, do you have any recommendations to help with that?
So one of the things I use here is like what we call freezy spray as I spray it on so that way you don't feel the needle as much. The other thing is I put in my injections some local anesthetic so it kind of numbs the joint up. And usually after a few minutes that pressure wears off because of that. We also recommend like later on in the evening doing some icing just to reduce the pressure and swelling around that joint from the injection.
Yeah, that's good to know. Are you familiar with low dose radiation for osteoarthritis? Is that something that we do at OSMS?
No, we do not do low dose radiation for arthritis. I don't know that there's any really great scientific evidence behind it. In the hand, they're using it for a few things, whether it be um, Dupuytren's disease or arthritis, but it's not really. I wouldn't say it's taken off nationwide or anything like that.
So this particular person says after having an x-ray, they were told that their thumb joint is severely worn. They've had two injections in their right thumb. The first one lasted about 6 weeks, the second one not at all. Will it hurt by exercising?
I would say it's kind of like one of those things where gentle light motion and exercise is recommended so that it doesn't get more stiff and more swollen and painful. But I wouldn't do like heavy exercise or aggressive activity with it, just because I think over the long run it'll be more painful.
Sure. Can you explain the thumb replacement you use, and do you take a tendon from the arm?
So there are a lot of different thumb reconstruction techniques. I learned multiple ones in fellowship. I tend to take one of your own tendons, but it's not the entire tendon. I take a slip of the tendon. It's called your APL tendon. So I only take a part of it, so it's still functional. And then kind of we take that little chunk of bone out that is kind of rubbing together. And then we use the tendon to basically create like a sling to prevent your metacarpal bone from kind of what we call subluxing or dropping down into that space where we remove the bone. There are other techniques where we use a suture. We basically suture the metacarpal into place so that way it doesn't fall down after that bone is removed. But all of the techniques involve removing that bone so that way those bones aren't rubbing anymore. I do have partners who use what we call your FCR tendon, which is one of your wrist flexor tendons, but you do have multiple wrist flexor tendons, so it doesn't usually bother people to do that. So most of the techniques, although they may involve, utilizing a piece of your own body, such as a tendon, usually the function afterward is not greatly impacted due to the loss of that tendon.
Yeah, great. Can you give more information about CBD treatment at all?
That's another one of those like very specific patient things. It's hard to know there's not really a whole lot of studies on it, but it's some things that people anecdotally use and say helps with their pain. I wouldn't knock it. I wouldn't say, oh, I don't recommend it or would never tell someone they should never do that. I think it's really up to your comfort and preference. If it's something where you're having a lot of arthritis pain and nothing else is working and you really want to try it, give it a try. I think the risk is low. If it works, it works. And now you have one more tool in your tool belt to help manage your pain.
Great. Looks like we have a few more questions. So what is the time frame for recovery for a thumb joint replacement? This person's a nurse, case manager, and they type all day. So how long would they approximately be off of work before they can type again?
So you're in like a splint, cast, or brace for probably 6 weeks total. And then the next 6 weeks we use to like wean out of it and start doing more therapy. So in total, the rehab process is probably 3+ months. So that's why a lot of people who are like, I'm not in a place to have surgery, that's why they say it, because they just don't have the time to take off work or something like that. Really, with any hand injury, I say, you can go back to work with just no use of your thumb because you'll still have these fingers free, but it's really also like a comfort thing. Like if you're taking pain meds and you're just uncomfortable, I wouldn't recommend going back to work, especially as a case manager, where you're dealing with people and things like that. Because you don't want to be taking pain medications and working. But like once your pain is well controlled, you can go back and type. You just wouldn't have any use of your thumb, but you could use these fingers.
Sure.
Mm-hmm.
Do you want to touch on our procedure room and the difference between that versus our surgery center?
Yeah, sure. So our procedure room is a little room down here in our clinic where we do minor hand procedures, and Dr. Henriksen does some minor foot and ankle procedures. Those are really just like local only procedures. So like a trigger finger or a carpal tunnel, they tend to be more soft tissue related procedures because of the fact that we don't have like x-ray or anything in there. But it's the kind of thing, it's like going to the dentist. You go to the dentist, they numb up your tooth, they fill your tooth, pull your tooth, whatever. You drive yourself there, drive yourself home, you can eat the same day. That's the same thing with our procedure room. We bring you in, we numb up your hand, we do your soft tissue procedure. You could drive yourself home, you could drive yourself there, you can eat the same day. The surgery center is usually reserved for more involved procedures that require things like sedation or x-ray or specialized equipment that involves more than some retractors or a knife. And so that one's going to be a little more involved in the process because we use anesthesia and things like that up there.
Great. All right, I'll ask one more question before we wrap it up. Do you just in general have any advice for anyone who is going through hand wrist pain and potentially may be needing surgery?
So I think the best thing you can do is probably make an appointment to come and be seen so we can really narrow down what the issue is, where it's coming from, and try to create a tailored plan that follows your lifestyle and your preferences. Because surgery, that's what we are. We're orthopedic surgeons. We do that all the time, but we know it's not something to be taken lightly, and it is serious, and we take it seriously. So we like to create a plan that works for you. And sometimes if that involves going straight to surgery, it does. But sometimes it involves, trying an injection or trying bracing or trying therapy to just get through and manage the pain before surgery. I don't think there's wrong or right answers really when it comes down to that. But I would definitely recommend just getting it seen, getting a set of x-rays so we can monitor it. Even if it's something where you decide, I don't want surgery right now, I don't want surgery in the future, but just knowing what you've got and what we're working with right off the bat kind of can help tailor your treatment to, like I said, your lifestyle and your preferences.
Yeah, absolutely. I couldn't have said it better. I mean, it's important that we touch on that we do have non-operative treatment options, like just because we know that there are different scenarios in which people may not be ready for surgery, but I think it's also important to note that we do operate on only less than 30% of our patients. So everyone who, if you have something going on, know that we will try other conservative treatments unless for some reason surgery is the only option. So that's something important to touch on. Dr. Chapman, do you have any other final thoughts before we end today's session?
I don't think so. I think that was kind of everything I had to say. If anybody has any further questions going forward, like please feel free to, make an appointment with me and we can go through it and talk about it more.
Yes, absolutely. Yeah. Like Dr. Chapman said, if you have any further questions and would like to schedule an appointment with us, you can do so by calling 920-430-8113, or you can schedule an appointment online at osmsgb.com. We appreciate all your thoughtful questions and for participating in our session today. And we appreciate your engagement and hope you found the discussion valuable. Just as a reminder, there will be a recording of this presentation available on our website within the next few days for you to play back if you wish to do so or to share with other people. So thank you again for joining us tonight, and we hope that you enjoy the rest of your night.